He's nationally renowned as an innovator within the field of advanced endoscopy and a master of resection of early neoplasia throughout the GI tract. Personally, as an advanced endoscopist, when we were making our agenda, I felt there was an insufficient amount of advanced endoscopy. So I thank Dr. Friedland for presenting today and giving me my fix.
Well, thanks for the kind invitation, and we better get started so we don't let you out of here late. These are my disclosures. So I'm going to focus on three hot topics. The first is GPOM and other endoscopic myotomies. The second is advances in endoscopic resection. And the third is gastrojejunostomy and other anastomoses. And interestingly, in the last couple of months, there's been two very great studies for the first two topics with level 1 evidence. So we'll start with GPOM. POM has revolutionized achalasia treatment for esophageal POM, but there's also emerging data on endoscopic pyloromyotomy, endoscopic Zenker treatments by POM-like procedures, and esophageal diverticula treatment. The question is, as far as GPOM, is it poised to revolutionize treatment of gastroparesis? Hopefully the video works. So this is an example of a GPOM, and the pylorus was spastic, as you saw there. We make a little bit of an incision here to enter the submucosal tunnel. Probably hard to speed it up. It's always takes a little longer than this. So you get in the submucosal space, you tunnel in, and here's where you start having to be careful. Because up till now, you could pretty much do whatever you want. Eventually, as you get to the pylorus, you want to make sure you don't keep going because the pylorus sort of takes a dive. And so we're looking to check that we're very close to the pylorus. We have to slow down here. I tell Mike a lot here to slow down so we don't go past the pylorus because here it is. So it's coming into view slowly. And once it's in view, you can cut it. The second part of danger, aside from kind of going through the duodenal mucosa on the initial part, is when you get into the serosal area here, the vessels get larger and larger, and we get into sort of non-endoscopic vessels potentially. So you want to be careful not to cause torrential bleeding. But usually the procedure is very safe. We admit the patients overnight. Not all centers do. So it's probably possible to discharge some of these patients at least the same day. But it's nice to sort of make sure they're doing okay in the morning before they go home. You can close the resection site with sutures or other ways. So what happens when you do this? Well, interestingly, there was just a fantastic randomized study from Czechoslovakia. Martinek and colleagues reported results of a randomized sham control study of GPOM. So a real sham group, they took these patients and they put them under general anesthesia for 40 minutes, making sure that they didn't just, wake up 1 minute after they went to sleep. And it worked very, very well. The primary outcome was a 50% decrease in the gastroparesis Cardinal symptom index at 6 months. It was met in 71% of the GPOM versus 22% of the placebo. So the study was stopped early by the IRB because it would be unethical to continue to put people under general anesthesia for no good reason. There were relatively minor adverse effects, 1 mucosal injury, 1 pyloric ulcer, and 1 admission for dumping syndrome. So this is a graph of what happened in the first 6 months. And you can see the blue is the sham. Not much happens to them in the first 6 months until they're randomized, until they're flipped over to the treatment. And in green is the GPOM. They do much better. Their GCSI scores go way down. After 6 months, the patients that were randomized to placebo to a sham got a GPOM. That was their incentive, I guess, for participating in the trial. And then they did very well after that. So it works. Surprisingly, I think to even some of us who do GPOM, because we don't always know who we're getting referred and how much is IBS, anxiety, etc. But the ones that have gastroparesis really do very well on in this sham trial. This is the 4-hour gastric emptying scan showing that it improves with GPOM also. So not just symptoms, but actual emptying time. So the second topic, now that GPOM is settled, gastroparesis, we don't actually know exactly who you should send, who you shouldn't send, at what point you should send. So there will be lots of other studies to guide us, but we can finally tell patients that it works. So the next topic I want to address is endoscopic resection. And ESD, we've been talking about ESD for a long time, mainly in Asia first, but then it spread to Europe and now to the US. We know it's very effective for early Barrett's cancers and for large rectal polyps that may contain cancer. We can do it in the colon, and the question is, should we do it in the colon? We know that when you do it in the colon, the recurrence rate is quite low, but we've never had a randomized study of that. So here's an example of a rectal lesion that is very appropriate for ESD. You can remove this by piecemeal EMR. You'll never know if, and we'll get into the data in a second, you'll never know if it had cancer in it or not if you remove it by piecemeal EMR. But if you remove it by ESD, you'll get it out in one piece with a clear margin. The pathologist will tell you exactly what the stage is. The recurrence rate will be under 1% typically. And the only drawbacks are that it takes longer. It's a bit of you get a bit of bleeding during the procedure sometimes. There's reimbursement issues, obviously, in the US. It may be getting better soon. But it does take longer than piecemeal EMR. Not a huge amount longer necessarily, because these lesions also take a fair bit of time to do piecemeal EMR on. But at least when you're done, you know that it's taken care of. You can close the wound or not close the wound depending on your preference and where it is. This case was in the rectum, so it's fairly routine to close it if you want to with suturing. It's probably impossible to close it with any other way when it's this size. But so this is hot off the presses in DDW 2022 from France, of all places. I really hope to visit this group and drink a little wine with them and figure out how they did so well and how they managed to organize such a difficult to organize trial, because they really did a fantastic job. Six centers in France, 11 endoscopists, 359 patients. And what they did is take 25 millimeter and larger colonic lesions. They excluded rectal lesions and depressed lesions. The reason for that is they felt it was unethical. ESD is so much better in large rectal lesions and in depressed lesions that they felt it was just unethical to offer a piecemeal EMR group for this. And what they looked at, the primary outcome was recurrence at 6 months, which was 5% in the EMR group, which is fantastic, better than anyone else in the world has ever really shown for large lesions of piecemeal EMR, and 0.6% in the ESD group. So basically it's 10 times fewer recurrences. So it clearly met the primary outcome measure. If you look at other things like R0 resection, that means a resection with a clear margin. So one piece removed with clear margins, so you know that the lesion is completely removed. That was 12% in piecemeal EMR, not surprisingly, because almost all these are piecemeal. Occasionally, you get a 25 millimeter lesion that you can take out in one piece. Versus 94% with the ESD group. Bleeding was very similar, 5.5 versus 7.9%. There was a surgery for complications. This happens. We know about 1% of ESD cases require surgery. We do know that the duration is longer, 113 minutes versus 71 minutes for the total procedure time in these patients. So it takes a bit longer, but it's worth it. The most interesting thing, I think, for me, and we've been talking about this for years, but we've never had proof until now, is that if you look at superficial submucosal cancers, so these are lesions, these are polyps that have a little bit of submucosal invasive cancer in them. So they're malignant polyps, but they're still curable by endoscopic resection if you get a clear margin. If you follow the NCCN guidelines, it's a well-differentiated tumor with superficial submucosal invasion and good histology, then they're curative resections endoscopically. So the rate of finding that was 0.5% of the polyps in the piecemeal EMR group, or in the EMR group had it, versus 3.5% in the ESD group. And there's only one logical explanation for this. You are missing 6 out of 7 early cancers when you do piecemeal EMR. So the reason why people have been telling you for years that there's very, very few cancers in the EMR is because they're missed. So you think about that, there's 3.5% of the lesions should have had cancer in them, but only 0.5% did in the EMR group. And that's what we've seen this in other organs. We know that it's true in the esophagus. We know that it's true in the stomach, is that the histology on piecemeal specimens is terrible. It's completely inadequate. You miss cancer all the time. And so you say that it was an adenoma, but it wasn't. Most of the time you get away with it, but anyone who's done EMR as long as I have you'll find occasional what's called invasive recurrences in the Japanese literature. These are patients that you thought you got it all. It looked good. It may have even looked good on your 6-month follow-up, and then they may have come back 3 years later with Mets in the liver, or they may have come back with cancer at the site, at the resection site. So you thought you did a great job, but really you did the patient a disservice. It's very disheartening when it happens. It's pretty uncommon because you can get away with treating superficial cancers with snaring them off and buzzing and cauterizing the margin and cauterizing the middle. And many times you get away with it, but not all times. So ESD is safe. It's superior to EMR. The pathology exam on piecemeal specimens likely misclassifies most superficial cancers as adenomas. I was going to present this slide because this is our experience, but then we totally got scooped by the French. So we basically had non-randomized data, and we can do the same thing that they did, but we were not organized. We did not have a randomized study, and we don't deserve to get the podium like they did. Okay, and the last topic I wanted to bring up, and this we don't have great randomized studies for, but for the right patient, it's a nice technique. And so these are endoscopic anastomoses, endoscopic gastrojejunostomy. Initially, and I was fairly hesitant also when people first started describing doing endoscopic gastrojejunostomy, is really, are you just showing us the ones where it turned out okay? Or what about the 3 that went to surgery for, peritonitis, etc. But as the technique has slowly been refined, I think it's at a point now where you can offer it in good faith to the right patients. It really and do them a service and not a disservice usually. There are also other anastomoses that we do. Of course, we do US guided biliary drainage and US gallbladder drainage. They're widely available. They're fairly routine now. Fairly easy to do usually. We let our fellows do many of them also. There is some risk always. These are little surgeries, so you can hit big vessels or cause other trouble. And for cancer patients, US biliary drainage is being compared to ERCP even. So if you come in, you're jaundiced, you have an advanced pancreatic cancer, you're going to need to get neoadjuvant treatment or palliative treatment. Should you do an ERCP, or should you just go right ahead and put in a lumen-opposing metal stent between the bile duct and the duodenum? It's actually a lot easier sometimes to do the US drainage. It can take 5 or 10 minutes. There is perhaps more risk of some devastating event like you misdeploy the stent and you cause peritonitis or something like that, but it's quite tempting. So there are studies in progress to compare these directly. But I wanted to talk about US gastrojejunostomy, which I think is sort of the next big procedure. And sort of got the seal of approval when my friends at Mayo said they're doing this now once a week or twice a week, because once the surgeon signed on, everybody believes that it's good. So this is what you do. You start by putting in basically a tube, a little feeding tube past the obstruction into the jejunum, and then you fill it up with contrasting fluid, and then it swells up the jejunum, so you can see you're infusing the contrast there. And so now your US scope is in the stomach, and you're deploying a lumen-opposing metal stent into the jejunum, but you're going into jejunum because you just filled that area up with your tube. That was the problem at the beginning, is people were trying all kinds of other methods, and sometimes you would do it into the colon, or you would do it into the ileum because you didn't know what loop was what. But now if you place in a tube past the obstruction and put in contrast and saline and maybe even blue if you want to make it colored, and fill up that limb, you can see that piece of jejunum is filling up during the EUS. And so you know that you're targeting the right place, and then it's also a bigger target. And so now that's really was the step forward in making this a safer procedure. And so these are the outcomes when you compare EUS versus surgical gastrojejunostomy. And these are generally cancer patients at this point, although it's becoming more popular in some cases for benign disease, but that's mainly for cancer now. And so you've had several several studies now comparing technical success, clinical success, and adverse events, and then recurrence or reintervention. So how often do you need to go back in and fix something? In the EUS gastrojejunostomy versus a surgical gastrojejunostomy. And you can see that all 1, 2, 3, 4, 5, 6 of these studies all basically show that the technical success and the clinical success is quite good in both groups. Some of the differences are in adverse events, where there tend to be more adverse events in the surgical groups. And then recurrence and reintervention is fairly good, actually, in both groups. So I think this is not the same as having randomized data, but these are patients who you really, they have often a very limited life expectancy. Your goal is to get them out of the hospital in one piece so they can go on to some treatment or enjoy, what's left of their lives. And it's very tempting to use this as a palliative treatment, in those patients. So in conclusion, GPOM is safe and effective for gastroparesis. Future studies will help determine the optimal candidates. How much playing around with meds and doing other things do you want to try? Do you want to try Botox injections or not? Can you predict who's going to respond better and who's not going to respond better? Those are still unanswered questions. But to a first order approximation, GPOM really works for gastroparesis. The second take-home point is, in a multi-center randomized controlled study, ESD was demonstrated to be superior to EMR for large colon polyps. Now we have to ask ourselves, which colon polyps are we going to do? Are we going to do all of them this way? I can tell you I do all of them now this way. But are there ones that benefit more? Sure, there's ones where you're suspicious that they have a higher chance of being malignant. If you look carefully and on NBI, for example, or on other techniques, you're looking carefully at the polyp and you're suspicious that there's an area in the middle that may be high-grade dysplasia or may be malignant, and that's an even better candidate to make sure you resect it in one piece. But if not, to a first order approximation, it's better to remove them all in one piece. The patients do very well. And then the third take-home point is that EUS-guided gastrojejunostomy and other EUS-guided anastomosis are increasingly utilized. And here is where it's a sort of a multidisciplinary approach is probably best to determine what's best for each individual patient. So thank you very much for your attention, and I'll take any questions. Yeah. So I would say that more than half of our patients that we do GPOM on have had Botox injection. It does scar the submucosa, so it makes it a little bit more challenging technically. When you've had one, I don't even think about it if you've had one or maybe two Botox injections first. Sometimes it's nice because the patient sort of, has a bit of a response maybe to the Botox, and they feel like they're invested in it and they're more motivated to go through the procedure. As you start getting into, 3, 4, 5, 6 Botoxes, it gets really scarred in there. So I think you're increasing the risk a little bit of causing a mucosal injury in the duodenum, which is usually fixable. You're making our job a little harder because we can't see the submucosal space very well, but it's still doable. Neil, I have to say that I have no idea who gets better with GPOM and who doesn't. I do them. They're referred from doctors that I trust, and I don't know. I really don't know. I used to tell patients that there was no good data to show that GPOM worked, but we'll do it if you want to. And now at least I feel like I can tell them there's really good data that it works. And if this is really bothering you a lot and it's interfering with your life, then we can do it. And if you want to do a Botox first and do that, that's fine. And if you don't, we can do it without it. Yes. Yeah. So the most risky ones are the depressed lesions. The least risky ones are what's called granular lateral spreading. So these are ones that are kind of lumpy, bumpy, but all the lumpy bumps look the same. Other ones that are, so those have the lowest risk of cancer, in large studies. They're also a little easier to cut piecemeal. The flat and depressed ones are harder to cut. If you look at an area, if you look carefully at the polyp and you see that there's one area, it may be all lumpy bumpy, but then there's one big lump. So those have a fairly high risk of having cancer in the big lump. And so before ESD, what we used to recommend is to remove the big lump in one piece and then remove the rest of it. But now we really just recommend removing it by ESD probably. Other characteristics that are worrisome is, if you use narrowband imaging, as many people do, and you kind of look at the pattern on the surface, and if it's all very, very uniform, then it's less risky. Whereas if you see some areas that are more irregular, then there's more risk of high-grade dysplasia or early cancer. So, as people stratify lesions, there are ones that have more risk of cancer and less risk. So if you're going to selectively choose which ones to refer, then that would make sense. The least risky are the ones that are serrated and look very, very uniform. So those almost never have dysplasia in them. And those you can do piecemeal cold snare on, and that works pretty well. But if it's a big serrated lesion and it has an area that looks like an adenoma, those are the ones that are dysplastic, and those